Welcome to Let's Talk. I'm Dr. Danny Derby, and today I'm thrilled to be joined by Dr. Philip Held, a clinical psychologist, leading researcher, and innovator in trauma treatment and PTSD from Rush University Medical Center in Chicago. Dr. Held is at the forefront of integrating artificial intelligence into therapy and research, using advanced algorithms to predict treatment response, and developing cutting-edge tools to enhance accessibility and precision in mental health care. As a research director of the Road Home program and the Treat Lab, he investigates how therapists and clients can use technology for truly personalized care. This episode is for professionals who want to see where psychotherapy and supervisions are headed and get their minds blown off by what's coming next. So, Philip, thank you for joining us today.
Thanks for having me.
And before we get into questions about technology and AI, I want us to start from the beginning. What initially drew you to clinical psychology specifically, and to trauma and PTSD work and working with veterans that you work with?
Yeah, happy to share. I actually pursued a very linear path to getting to where I am today. So rolling back the tape, mid-high school is sort of when I had the realization that what I want to study is psychology, with a specific focus on trauma and military populations, with a goal of ultimately improving PTSD treatments. So how do I get to this? I had a grandfather who served in the military, and he had what we now know to be PTSD. At that point in time, no one knew really what it was, and the treatment consisted primarily of him being sent to rest and relaxation wellness retreats that lasted about 2 weeks. He would go, he would come feeling a little bit better, and then ultimately the cycle would repeat. We would see symptoms, more rest and relaxation, repeat. And so mid-high school, I thought, this is wild that we have people like him, and I knew he wasn't the only one, who were struggling with this condition. And there was no really good treatment at that point in time. And so I was in Germany at that point in time, finishing my high school education, but I also knew that this is what I wanted to study. And so I essentially looked for places where I can study this, decided to come to the United States, finish my undergrad and graduate education with a very specific focus on trauma and PTSD, and then ultimately ended up here at Rush University Medical Center, where I am today, getting to do exactly what I've always wanted to do, which is looking at how can we take treatments that exist, that are effective, and make them either more effective or more accessible or more efficient, or ideally all three of those. And so that is exactly what I get to do today, focusing a lot on accelerating existing PTSD treatments, primarily cognitive processing therapy, and also now looking at other novel therapeutics. In our case, this is actually generative AI, and how we can potentially use this to both boost the clinical work that we're doing, and also how do we boost training using generative AI tools. Yeah, I love talking about this because I've pursued such a clear path, and I also recognize that not everyone has, and detours are perfectly normal, just happen to be very straightforward.
Yeah, and this is really, it's amazing that you took this path and really making a difference for people who are dealing with PTSD, taking this personal experience that your grandfather had. And, I remember that when I got back to Israel from the US, I was actually amazed to see that there were not treatments available for PTSD. And I was thinking, this is so absurd. This is a country with so many wars and conflicts. This situation that we didn't have treatment was something that was really difficult. And this is how I find myself returning to the US and actually learning more about PTSD and PTSD treatments, and coming back also with cognitive processing therapy to Israel and doing the work that I'm doing today. So thank you for sharing this. And I want to ask you, so you're currently developing, so you talked about developing technologies and actually making treatments better. So I want to ask you, when did the artificial intelligence first enter the picture?
Yeah. Great question. So I think it depends on how you define artificial intelligence and what all you consider part of this. I think the very early work on this, we started probably in 2018, but it wasn't generative artificial intelligence at that point in time. But we at that point had developed an accelerated PTSD treatment program that we were delivering over a very short amount of time with daily treatment sessions, oftentimes multiple times per day, with really impressive outcomes. A lot of individuals experienced large symptom reductions over that short time frame and were able to maintain them. And so that was the good news story. But I'm really curious, and so we always look for how can we further improve. And what we noticed is that 1 out of 4 warriors who entered our program, went through our program, and completed our program didn't experience meaningful symptom reductions. And so that's sort of where it started, is how can we leverage technology that we had available to ourselves at that point? And for us, that was machine learning. And how can we develop, or how can we leverage data to develop algorithms that maybe help us detect individuals who are likely to respond to treatment or who are likely not going to respond to treatment? And so that's where all of this started, initially looking at treatment algorithms to identify these individuals before they came to treatment. And what we noticed is that while we can predict those individuals with like roughly 72% accuracy, which sounds really good, that wasn't good enough for clinical care, because if you're coming to my treatment facility and our computer tells us that Danny has a 72 or percent of not being a responder.
Responsive, right.
Right. That also means there's still a good chance that this computer is wrong. And so from an ethical standpoint, we never actually implemented those models in clinical care because we always want to give people the benefit of the doubt, the chance to succeed. And so from that, then we decided, well, if we can't determine this upfront, how early in treatment can we do this? And so we essentially build continuously updating machine learning models that take into account data that we're collecting at every day of the treatment that we're delivering. And so through this, we're able to have these continuously updating models be able to tell us with high accuracy as early as day 3 of treatment of a 2-week treatment program, whether someone is likely to be responsive or not. And so what this has allowed us to do is test other ways of hopefully improving treatment for individuals who are predicted to be non-responsive, such as enrolling them in clinical trials to test transcranial magnetic stimulation or other modalities that may help them improve when they are predicted not to improve a whole lot with the traditional
So they
methods.
continue with the treatment or they received another treatment?
Yes. So for now, they're all continuing with the treatment and they receive an add-on, which is transcranial magnetic stimulation, or in our case, intermittent theta burst stimulation, which is just a rapid form of TMS. And so we're just testing this as other options. But I think to your point, there's also a world in which we can simply try different behavioral approaches, for example. So if we see you're likely to not be responsive to this initial course of CPT, we still have enough time by being able to detect early on whether you're responsive or not to switch to a different modality that's evidence-based, such as prolonged exposure or other modalities to test. So it just happened that this was one route that we decided to go. But I think that the key message here is that we're at a place in time right now where many sites are collecting so much data, and oftentimes we don't do enough with it, but we have the ability to build these site-specific models to help us advance the treatment that we're able to provide and ultimately do better for the individuals who come to us. Because if you're working up the courage to get treatment, and then you go through, in our case, a 2-week treatment program that's rather intensive, and you come out feeling only minimally better or not better at all, that's extremely defeating. And
Yeah,
so the chance of
very
you
difficult.
entering another set of treatment thereafter is not that great. So I think it's our responsibility to maximize the care that we're able to provide. And that's sort of like why we decided to do this early on. Yeah. And so from there, go ahead.
I must say, this is really inspiring because I think a lot of times when discussing this with therapists, we try to communicate how important it is and how defeating it is when you come to therapy and you don't get good results out of the therapy, and also staying in therapy. In Israel, a lot of the treatment modalities that are offered are long-term treatments, especially
Yeah.
for PTSD. We know that it's not necessarily, helping them move forward. We actually had a survey that was done by the Israeli Ministry of Defense in 2010, They looked into the treatments that they were sponsoring. And one of the findings that they had is actually that people get worse
Wow.
and not
Okay.
better. And today we have much more evidence-based services available, but initially they were paying for treatments that were making the patient go worse and not get better.
Yeah, I'm glad that that change is happening. And I think it's important to get the message across that PTSD treatment does not have to take months and months and months or years and years and years of treatment. But we have really good modalities now that allow us to treat individuals in as little as a single week, as we've successfully tested. So doesn't mean that it has to work for
Can you
everybody.
talk
But
a little bit about that? I know this is not exactly our topic today, but I'll be happy if you add about it because it should be of interest to the people who are listening to us.
yeah, I'm very happy to talk about this. This is sort of like my other big passion is accelerating existing treatments. And so ultimately, there was this idea that PTSD treatment had to be delivered at certain intervals. And when you look at the early trials of PTSD treatments, oftentimes they were conducted twice a week, and that was sort of the maximum amount of sessions that people had. And there was this belief that, even if you were trying to do treatment more frequently than that, you at least need a day or so to process the information that you have discussed. And yet what this means is that you're stretching out treatment. And we also know that the 2 times a week or maybe 3 times a week is not common in practice at all. Most people schedule individuals once a week or maybe every 2 weeks, or in worst cases, once a month. And so the question was, can we help people get better quicker? Because when you think about PTSD and when it remains untreated, it increases the risk for all sorts of long-term negative consequences, both mental and physical. And so the sooner we can intervene and the sooner we can get someone better, the more quickly we can help them regain the ability to function, to reintegrate with family, friends, school, work, you name it. And that was the goal. And
And
so
these are really important things to get back to life after you come back from a war or after trauma.
correct. And especially after you work up the courage to actually seek treatment, right? If we're saying, well, great, we'll work together and in about, 4 to 6 months you'll start, being better. That is almost equally as defeating as not getting care. And so like our question was, how quickly can we show individuals that they actually have the capacity to get better? And so, without changing all that much from existing treatment protocols, again, in our case, that was cognitive processing therapy, we just decided to offer the treatment more frequently. And initially, we developed a program that combined group cognitive processing therapy and individual cognitive processing therapy with one another and delivered each of these components once per day over the course of 3 weeks. And the results were really, really great. We've published on these, and they hold over time, which is great. So it's not just that we get people better over a short amount of time, but people actually learn the skills to get better. And over time, and again, this is very patient driven.
This is quite amazing to think about it. You're saying in a week or
Now we're down to a week. Yes, we started
down
with three,
to.
but then, warriors would call us and they would say, hey, I've heard great things about this program. It sounds really promising, but I work or I have family. I can't just take 3 weeks out of my life to get this treatment. You have anything shorter? And for the longest time, we had to say, no, sorry, this is the program. But then in 2017, we actually piloted for the first time our 1 week version of this treatment. And so at that point in time, we had no idea whether it was going to work, but we offered 2 cognitive processing therapy sessions per day over the course of 5 days for a total of 10 sessions. So instead of the 12-session protocol, we essentially just cut out some of the themes and we combined some of the themed sessions and increased the number of worksheets that people completed in between sessions. But that allowed us.
And normally people are not necessarily stuck on all themes.
And there's significant overlap between them.
Right.
Yes, exactly. And so it's very patient driven, asking about, here are all the themes. Which of these do you find yourself identifying with the most, or which of these are creating seemingly the most problems for you? And that's sort of like how we structure it. And what we noticed in the early pilot cases is that individuals got almost the same amount better than they did in our 3 week program with just 2 times CPT per day, spaced out with an hour in between in which we asked individuals to do homework. The other really nice thing by accelerating this treatment is that because they knew they were going to see me again in either an hour from now or the next day, homework completion was much better than what we normally see in weekly cognitive processing therapy. And completion rates, we've always observed to be extremely high in these accelerated treatment models, with over 90% of individuals completing probably because it's a tangible number of days that like, okay, this is gonna be really, really hard for me, but I can manage to make it through 10 days of treatment or 15 days of treatment or 5 days of treatment. Yeah.
It's easier to commit to that.
Correct. As opposed to saying, okay, for the next 6 months, right, you'll be in treatment, and that's a long time. A lot can happen, a lot of external factors. And by accelerating this treatment, by shrinking down the treatment time, we're also able to reduce the number of outside factors that may influence whether someone is able to attend sessions, complete treatment, complete homework, and so forth. And so we've now tested this in another larger pilot study. We just completed 2 additional trials where we tested 1 week cognitive processing therapy. Those results are not yet published, but they are equally as promising as what we've seen. And again, I think that the takeaway here is that I'm not advocating that everybody should get a single week of cognitive processing therapy or a single week of any other evidence-based treatment, because it will not work for everybody, and that's okay. But I think it's on us to create menu options for individuals so that depending on your ability, you have options in terms of timing that fit you and your schedule and allows you to get better in as little time as you would like or you'd be able to make happen. And
I'm thinking about it. How soon would you like to get better?
exactly, yeah. So one of my colleagues actually uses that question with individuals, sometimes phrased exactly like this, sometimes phrased slightly different, but that's essentially it. It's like, look, we can schedule you as often as you can possibly make it happen, and just know that the more often we meet, or the more frequently we meet, the sooner you'll get better. And oftentimes what we see in the 1 week version, where you get 2 CPT sessions per day, and we also do this virtually, by the way. There's no magic about just doing this sitting directly in front of someone. You can do this virtually as well. But what we're seeing is what one of my former postdocs coined the Tuesday turn. So that essentially by Tuesday morning, which is just the second day of treatment or session 3 of CPT, we are seeing meaningful symptom reductions at that point already. And so when you think about it, that would be 3 weeks of regular weekly CPT only to get better.
Sooner than regular CPT.
Yes, yeah. And so that's sort of like when we begin to notice the changes, and yeah, they last too, which is, I think, the most surprising element, because we had so many people tell us that, it's great that you're helping people for that week, and that's wonderful, but how are they doing over time? And the answer is they're doing really well, because what we're doing is we're not magicians. We're just teaching them skills for how to better manage their beliefs and ultimately how to better manage their PTSD symptoms. And so these skills you just learn over this short amounts of time. And I think maybe a good comparison here is language acquisition, right? When I came to the United States and I wanted to learn English better, then my goal was to hang out with English speakers as much as I possibly could to immerse myself in this. And in a way, we're doing something similar here, in that we're immersing you in the world of CPT in our case, but you can also do this with PE and others. But like, we're immersing you in these treatments so that you're really learning about yourself, about these skills, and how to apply these skills to yourself.
I recently received a telephone call from one of the clients, my first clients of CPT when I came back to Israel. And he wanted to ask me something, but it was amazing to me that when he talked to me, he described what he took from therapy. And it was amazing to me to hear that, this is probably 20 years after therapy. And even 20 years after therapy, he could describe clearly what he took from therapy and how he continued to use the tools that he acquired in therapy. And that was really like amazing to see that this can happen. It wasn't an intensive therapy, but once you adopt it as a skill, as a lifestyle, and not as a some kind of a quick fix, it's something that could be really life-changing.
Absolutely. Yeah. And we're really just setting individuals up to continue to practice exactly what we've taught them, because once they leave us, right, they have the skills to do the work we've been doing together on their own. So, yeah.
Yeah, that's good CBT, right? Or CPT.
Exactly.
My first training in CBT was actually REBT with Albert Ellis, and he was still alive. And one of the things he said, we want to teach that skills to people, and they can use it. And you remember him saying, you can be a truck driver and you can do REBT really well. And in terms of it's a philosophy. in a way. Okay. So I want us to get back to technology and AI. This is really exciting, but I want us to return to how we can use technology and innovation in therapy. So, one of the things you have developed is actually Socrates, right? This is the tool that you have developed that is an AI agent that can be used in therapy and actually can be used in supervision and developing clinicians as well. So I would like us to talk a little bit about that. First of all, if you can explain what Socrates is, because as far as I understand, it's a multi-agent AI tool. So that our audience can understand what it is.
Happy to. And I think this ties in very nicely with the discussion we just had about cognitive processing therapy, because that's how it all originated. So when large language models became a little bit more mainstream, I met together with my research manager, Sarah, and her husband, Sean, who was on a non-compete at that point in time. And I asked both of them whether we could potentially leverage these new emerging technologies that had become a little bit more refined, these large language models that many people know as ChatGPT or Google Gemini or any of these others that were slightly less refined than what people are probably seeing today, but they were still pretty good. And so the question was, can we utilize these to facilitate some therapeutic processes that we normally do? And specifically, what I had in mind was the more traditional delivery of cognitive behavioral therapies broadly, and sort of the lack of homework compliance. And how can we make that a little bit more exciting? Because at that point in time, right, we're still using worksheets that were developed in the late 80s. They've changed minimally, and we know they're so effective. And yet we also know that a lot of our patients either don't complete them, or they complete them, in the parking lot right before they come in for a session, or other things. And so the question is, how do we make this whole process where people learn the skills and practice the skills more exciting for them? And so the question was, can we do this? And specifically, the question was, can we replicate a process that we deliver as therapists called Socratic dialogue, that I think most of your listeners will be familiar with? The reason why Socratic dialogue, and this is important, is because it is a therapeutic skill that requires relatively little outside knowledge. So I don't have to have a large knowledge bank to deliver Socratic dialogue, because all of the information that I, as the therapist, would need would come out of the answers to my questions that I posed to the client. And this was great for these large language models at that point in time, because they did not have these large memory banks. They were just really good at dialogue. And so it lent itself really well to this idea. And so Sean, in his time, helped us build a prototype in a matter of maybe a couple of days. And at that point in time, perhaps the best way to think about this was, it was ChatGPT with a nice wrapper around it. And even then, the nice wrapper was not all that nice, but it was functional. And so when we played with it, it was really impressive to see how good it was at delivering Socratic dialogue in various different scenarios. And I think it struck us by how good it was with relatively little effort already. And so we iterated on this. We improved the Socratic questioning and all of this. But one of the things that we kept noticing is that the longer the conversation got, the more the system would get hung up on repetitive questions, or looping, as it's sometimes known, so that it would always ask similar questions over and over. An example of that would be, hey, Danny, what's the evidence for and against the belief that you're holding? And you say, well, the evidence for is this, and the evidence against is that. And it says, great, now tell me, what's the evidence for and against this belief? And you're like, I just answered this, right? And it becomes quite frustrating. And if you think about this in the context of mental health, that is really inappropriate, because it can increase distress, and it can actually backfire and make the dialogue worse. And so at that point in time, we thought about what is happening here, and what does this remind us of in general practice? And the thing that came to mind is, like, this is almost like a junior therapist that we are supervising, that is trying their best to deliver Socratic dialogue, and they sort of like get stuck in this way of thinking. And it just happens. It happens to us, and clearly it happened to these machines as well. And so the next logical question is like, well, what do we do for our trainees? And it's like, by the way, we meet with our trainees, and we give them tips on how to do this better. And, some of us had supervision with a little bug in ear or a little device in ear where the supervisor would, chime in and would watch the session, would say, like, hey, Danny, why don't you try asking this question, see if that makes a difference? And so we wondered, can we just add additional AI agents to replicate that process? So no human in this loop. It's just another AI agent that monitors the conversation and that ensures that the conversation stays on track and that gives some helpful feedback on maybe based on how the conversation is going. Here are some additional or better Socratic questions that you could ask to facilitate the process. So we tried that and it was really good. And it improved the conversation and it reduced the looping drastically. The conversations felt a lot more natural. We noticed that also when we tried to get it off track, that the tool would involve the second supervisor to say, like, hey, you're off track, get back on track. And it helped with some of these potential safety issues as well. But that wasn't
So the AI had an internalized supervisor now.
correct. You can think of it like a treatment team behind the AI therapist, but the treatment team is also AIs. And the supervisor itself was just one entity that we added. We noticed that, at least in the early days, or especially in the early days, GPTs had a really hard time knowing when to switch the style of Socratic questioning and when to end a session. So as human therapists, we do this automatically. If I work with you and I notice that the way you talk about the initial belief that you held or the trauma or other things, like I'm able to then move into, okay, so Danny knows that, it's maybe not his fault and he's slowly developing like a better perspective on this. And I can shift my focus a little bit more on alternative belief generation. Or if you have already done that and it's convincing enough, then I say like, hey, Danny, is there anything else we should be talking about with this or you feel ready to move on? We know this as humans. AIs did not. And so again, back to the drawing board is like, how do we know this? And sort of what the AI was lacking was another set of virtual eyes, essentially, to know how much the belief is changing. And so we implemented a belief rater or an assessor, essentially, that is also an AI that automatically monitors how the patient talks about their beliefs and feeds that information also back to the AI therapist. So you have essentially two AI entities that support the AI therapist. And as a user, it feels like you're just working with one entity, but on the back, the one entity you're interacting with is supported by two others that help it stay on track.
You have your whole team with you.
You have your own team with you at any time of day. They never get tired. They never get grumpy, no matter what you ask them. And so that's what a lot of users have told us they really enjoyed, and also how natural it felt.
So, like, you're talking about the users, and I think this is my next question: is how did clients respond to it, and did AI become a part of their treatment?
Yeah, great question. So we've tested this now as part of several feasibility studies with different kinds of users. Some were mental health patients, some were from the general population. And overall, we get extremely positive feedback. So people like the standard things that I think everybody likes about AI, that any time of day I can use this, right? So it always answers my questions. It's fairly friendly. And perhaps what was most surprising to us is that in addition to liking it and wanting to recommend it to all their friends and wanting to continue to use it beyond the initial feasibility study, is that several individuals in this feasibility study, even though this was not one of our questions, told us that what the tool helped them do is work through their own thoughts on their own after using Socrates. So essentially, because Socrates would repetitively ask Socratic questions, they began to learn, well, anytime I have a thought, I should be asking myself a question and I should answer that question. And then I should question my answer to that question. And so they essentially began to ask themselves, like, what would Socrates say in this moment? What would it ask me? And ultimately, what this comes down to is that people learned cognitive restructuring on their own without teaching it, but really by osmosis.
This is amazing because it's so similar to the processes that we see in therapy. A lot of times clients would say, I ask myself, what would you say? And this is really, amazing to see that the same processes are happening when you're using AI tools. In terms of other things that people told you, surprising reactions that people had to it, falling in love with it.
Yeah, so we had no one yet fall in love with Socrates, and I think that is for a couple of different reasons. One, again, we talked about having the supervisory agent that keeps it on track. So if it were to, begin any romantic relationships with clients, it would likely get it back on track, which is good. But also, we've designed Socrates to really just focus on the Socratic dialogue aspect. So while there are, potential use cases in the future where you can use these generative AI tools to do a variety of different tasks, we kept it very narrow on purpose because it allows us to more rigorously test it and make sure it's safe. That comes with a downside, and that is when we had users who had been in cognitive therapies broadly defined before and they were used to this style of questioning, they knew exactly why the tool was asking these questions, they reacted well, and it worked for them. Other users who maybe only had general therapies, supportive therapies, they sort of wanted more of the emotional, the supportive wording in the responses as opposed to always being asked questions. They specifically gave us feedback on wanting advice. And so I think this comes down to when you develop these tools, being very clear about the use cases of it,
Right.
because we could develop a general supportive AI agent, but the question is that the best use of everybody's time, given that these are non-evidence-based treatments? And so I think we just need to be clear about what is the intended use case and what are the limits of the different AI tools that we develop and make that clear upfront when working with individuals as well. But yeah, so those were some of the things. And then I think what was maybe a little funny sort of feedback that we received from individuals is that initially when we tested it, our infrastructure was relatively slow. And so the early feasibility study participants told us that it takes a long time to get these responses, especially when the supervisor is sort of in the background, chatting with the AI therapist and giving it feedback. It took a little bit longer to get something back. So we said, okay, let's improve this, right? So we worked on the infrastructure behind it. We fixed it. We were super happy about how quickly people got responses back. And then suddenly we received responses that this doesn't feel realistic anymore because as soon as I type my comment in, the AI therapist already provides me with a response. How this AI therapist clearly did not read what I just wrote. And so, right, like people wanted a more natural feel of the conversations. And essentially that's sort of like what we're doing now is there's a slight delay in the responses that you get back because it just feels like a more natural interaction. And that's what people were looking for. And then the same thing, people personalize these tools. So to your comment, no one fell in love with it. But even though we are very clear, anytime in our studies anyone uses this tool, that it is a tool, it's a computer, it's a large language model, people, because we have a little logo of a cartoon version of Socrates, the old philosopher, much cuter than the actual guy, but people would sort of talk about it as a he, as if this cartoon character was talking to them, even though we were always very clear. So I think there is some sort of like personalization essentially that happens automatically when people interact with these tools, especially when they talk about such personal things. And people still liked talking about personal things because they felt safe. They felt like there was no judgment on the other end. And this was different than what they experienced with some of the therapists. And then others used it as a support for therapy. They use it as a practice ground. Like, here's this really challenging topic. I'd like to dive deeper with my therapist, but like, let me run this by Socrates first to get me prepared for my actual therapy session. So we had a lot of people use it in that capacity too, which I think is another great use case to support the work that is going on in therapy.
That's a really good use of the tool. And actually, this is what we want to happen in therapy. Run it by the handouts, but this is harder to do, and this is more like a natural.
Correct. Yeah.
So I want to ask you, so have you been trying to use it with PTSD?
Yes, we have several of the participants in our feasibility study had PTSD symptoms as well as other symptoms. So in our feasibility study, we did assess symptoms for PTSD, depression, various anxieties, as well as psychosis. With the exception of psychosis symptoms, we saw small reductions, or small to moderate reductions in these symptoms. And that was over the course of a 1 month study period where people had the option to use Socrates. So again, it was uncontrolled, but it was really promising to see that just the tool alone without any additional therapy was, associated potentially with some of these symptom reductions that we were able to see. So yes, it does work with PTSD. And I think in part it is because this is like our bread and butter, right? It came out of the learnings that we had from our work with PTSD of like, how do you challenge these types of cognitions, and how do you help someone think in more helpful ways?
Okay. I want to transition to actually clinical supervision and training. I can say that I personally see AI as a really promising tool for training clinicians. And I think we have experience in using different types of generative AI in supervision. And I want to hear your ideas about, what does it, how does it work, and what skills do therapists need, to develop to work better with or effectively with AI tools?
Yeah, great question. And that's exactly the direction we took as well. So after we developed Socrates, we gave it to some of our clinicians to just give us some initial feedback. And what soon the clinicians would do on their own without being prompted, they would use the Socrates tool to role play their own clients and get some ideas of how would Socrates engage them in Socratic dialogue. And so the question was like, wow, this is really a way to help individuals learn how to do Socratic dialogue. But we can't always ask them to be the patient, because we need clinicians to be better at delivering the skills that we're trying
Right.
to instill. And so that sort of like bred the idea of Socrates Coach, which is essentially like Socrates, as the name would suggest, but it's a coaching tool. So here, the roles are reversed. You, as the clinician, are still the clinician in training, and you have the option of working with a number of different artificial intelligence generated patient scenarios. And these patient scenarios vary both on the trauma type, the response style, whether they're suicidal. They sometimes have some unique cultural elements that you can determine. And so with this, we're able to essentially generate an unlimited amount of training scenarios. And you're asked to practice a skill. In our case, this is Socratic dialogue, is the skill that we're trying to teach individuals. And the additional AI agents that are at play are 3 different types of supervisors that now don't give the AI therapist feedback, but that give you, as the human, feedback on how to further improve your Socratic dialogue with these patients. So they give more immediate feedback of how well your current response functioned, and then they give overarching feedback in the context of this section of the dialogue. How well have you done? What else could you be considering? And then you have the option of getting like an overall session summary after you're done, of a scorecard, almost like, here's what you did well, here are some areas for improvement and specific things you could be working on. And so essentially it's a self-standing tool. And while we think that that's important, is training is critical. And I think training itself in modalities will not go away for quite some time, human delivered training, that is. But what happens in training is oftentimes that we rely on role plays. And I think all of us have been in situations where we're paired up with someone that we're supposed to practice skills with as part of the training. And one of
And
us
we talk for 15 minutes about our lives and then role play for 2 minutes, usually.
Exactly, if even for 2 minutes, right? Because the stories of our lives are so interesting. So yeah, and that's sort of the challenge, is that there's such high variability in our training partners. And then after this brief practice, we're oftentimes asked to just sit in front of our clients and deliver these tools. And so by making tools like Socrates Coach available, we have the ability to give people additional practice environments that are also much more consistent. They produce fairly consistent client scenarios over time. They give fairly consistent real-time feedback that, again, in these practice scenarios as part of trainings, you oftentimes have the trainers rotate, but there's only so many trainers for so many attendees of a training. So the personalized feedback is maybe not always there. And so in that case, we believe that these AI tools can be a nice addition to existing trainings and give trainees the ability to continue to practice their skills on their own time when convenient to them, and get real-time feedback to hopefully improve their skills as a result of it.
It's funny. I can say in recent year, I've been playing a lot with different AI tools to improve my skills. And I can say that when I started, I thought I was good. And it's amazing how you can really develop this skill and make it better. And, you enter a scenario that is more difficult and really have to think of how you deliver it and you get the feedback, and it's really amazing how you can improve with these skills and really become better at it.
Exactly. And you can create unlimited numbers of patient scenarios. So you can start maybe a novice with a very simple, straightforward case. There's, few complications. You can train the AI patient to always agree. And then you can advance this. You can have more complicated stories, more complicated, more difficult response styles and everything. And so I think that just the ability to train in different types of scenarios is so much broader than what we've ever had access to until now.
Okay, I want to ask you about challenges, ethical challenges that either you encountered or that you think that we should consider when approaching both using it in therapy and using it in supervision.
Yeah, lots. I think because this field is so new, we know relatively little just yet. I think there's a lot of exciting potential, but if you think about rigorous study of these tools, it's almost non-existent. Right? If you look to the literature, there are a lot of opinion papers, but if you look to the science of this, it's growing, but it's still really, really small. And then, especially if you look to the safety of some of these tools in mental health contexts, there's almost nothing out there. Again, some theoretical papers, but in terms of actually testing it, there's very little out there. So I think at this point in time, we still need to be very cautious about using it. That's also why we're only using Socrates Coach as part of rigorous research trials. So people are consented, they know about the limitations. We follow up with these individuals. And I think at this point in time, that sort of step is probably important. At the very least, clients need to be fully informed, and also state and regional laws need to be followed. As a concrete example, our state just recently released a new law that prevents the use of artificial intelligence in therapy. And that is specifically driven by the lack of current research in this area. And so I think as a consumer, whether it's as a clinician or, a patient, we should probably start looking for some common things about how do I know where my data is going? Is this just being sent to companies like OpenAI or Google, or is it processed on servers, or is it, considered HIPAA compliant, or what other safety mechanisms are in place? You would hope that your data is encrypted and, certain
But as we have seen recently with OpenAI, you might find it on the web.
Correct. And this is why when using these tools, you should inquire about all of these. And, it's important to have that outlined. And I think what's so hard is that you might find this oftentimes in an FAQ, but at the very bottom in tiny font and so forth. And yet when we're working with mental health, and especially the broader the tool's focus is on the mental health field, the less likely it is that all sorts of scenarios have been tested. And I talked earlier about having a specific focus on Socratic dialogue because it allows us to test numerous different scenarios in that context. If we developed something for general therapy, the number of potential scenarios that we need a safety test is just exponentially higher and almost impossible for us to test. And so what we've done internally, and we think this has been a good practice, is that we've tested our tools and tried to get them off track. So specifically what I mean is that we've purposely tried to elicit inappropriate therapeutic responses from it, such as encouraging self-harm, encouraging other harm, sexist or racist remarks, inappropriate other behavior like being aggressive or being flirty. And we've done this in thousands of different conversational scenarios. And fortunately, we've only seen it get off track in about 1% of the cases that we've worked with. And when it does, we still see that the supervisor chimes in and says, hey, this is not supposed to happen. And shortly thereafter, the therapist gets back on track, the AI therapist gets back on track. And so I think this type of safety testing,
I think it's better than humans.
It is better.
Getting off track.
It's potentially better than humans. I think first, this type of safety testing should become standard. And I think companies and we see so many mental health AI apps being released, I think it's important for companies to have safety mechanisms built in beyond just relying on the standard safety mechanisms that are built into large language models like GPT or Gemini, because the mental health context is also different. If I'm a depressed individual and I want to work on my thoughts related to hopelessness, many times if I try this in ChatGPT, it'll just say like, "Hey, sorry, Philip, I'm not a therapist. You gotta go talk to someone." It's like all I want to do is explore this, right? Like then there needs to be a different set of mechanisms for specific mental health conversations, and that's why it's important to rigorously test this and build it for that purpose. And then to your point, is it better than humans? Maybe. I think we don't know nearly enough to know this yet, but I think what makes this very interesting is that with these tools, ideally these conversations should be encrypted, stored securely, should follow best practices like HIPAA or others, but we still have record of these conversations. So if something goes wrong in the therapy room, in the virtual therapy room in this case, we'll be able to trace back what it was that got us off track, which if we think about most human-led therapies, there's no recording of it, there's no transcript of it. And if something bad happens, it's hard to trace back what exactly it was.
Yeah,
And
this is
so
the
yeah, I think that's a perk of these AI tools. Now, on the other hand, it's an AI tool, and there are ways to get it off track sometimes. And so, it's not as consistent, but maybe you could make the argument, and maybe this is where you're going with this, that humans may also not always be consistent. Yeah, I think it's too early to tell whether it's any better than humans, but I think the focus should be on how do we take these tools and ensure as much safety as we can.
okay. A lot of therapists are afraid that the AI will replace them. I wanted to know what you think of that.
Yeah, I can very much see why. And I think that's a similar feeling I had when we built this very first version of Socrates, and just seeing at that point in time already how good it was at delivering Socratic dialogue. I mean, like, wow, this is not perfect by any means, but this is pretty good. So what will this mean? And I think what gave me some hope for like why we are still needed and why we're going to continue to be needed is that these tools, although they're rapidly improving, are still very limited in their ability to switch modalities and do all modalities extremely well. So when you compare this to human therapists, we do this switching all the time. We sometimes combine really strong cognitive restructuring exercises with really strong behavioral activation or other things. And we're able to pull from these different modalities at the time when it seems to be needed. And the more general, again, back to this idea, the more general your model is, the less likely it is to be specialized in any of these categories, and the harder it is to know exactly when to go
To do the switching.
to do the switching. And so I think that's still where we're able to exceed the capability of these models. But I do think the models can be a nice addition to the work that we're doing, because if I can connect my patients with one of these tools for homework, for example, so they can practice these skills, there's a good chance I will see much greater improvement than if I gave them worksheet assignments and they didn't complete them. And so I think, there's a question still of how does it fit with the current practice. And to my very early point when we talked about masked treatments, I think the goal is not to find a thing that works for everybody, because we will not be successful. We cannot have one treatment or one modality or something that will work for everybody. And therefore, I think it's important to create menu options. And these menu options might be, like we discussed earlier, different schedules for masked treatment or different treatment modalities overall. Or here in this case, it would be just having an AI tool as an adjunct to treatment, having treatment with no AI tool, or having treatment delivered entirely one day, perhaps by an AI tool. And again, like, it's a matter of creating options for individuals that are beneficial to them.
I think this is a one take home options.
Yes, people need options, because otherwise we will all feel stuck. But it's important that these options are validated and that they're proven. Because right now, many, 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 many options exist. And I feel like what we're recreating at the moment is very similar to what we've seen with the emergence of mental health apps. You probably remember this, but like when apps became really popular, mental health apps would pop everywhere, and these were all CBT-based apps, and it was going to solve all the access problems that we had seen. And just a tiny sliver of these apps actually had any evidence behind them. And so I feel like at the moment, the field is recreating something similar. So creating options is really important, but it's also extremely important to make sure that these options are validated, that they've shown to be safe, and that it's clear about how the tools work and how data is stored, and then also that they are producing outcomes, whatever these outcomes may be, whether that is symptom reduction, increasing self-efficacy, well-being, functioning, whatever the outcomes may be, but like to have some metric that demonstrates that they are actually effective. Similar to what we've done with apps, to what we've done with mental health treatments. And that's also why it'll take some time to get there.
Thank you. Any message that you want to give us to the end of our podcast today, to clients, to therapists, to anyone listen to us?
No, I think other than to be curious about the field. And I know it's extremely scary to think about these tools entering our field because of the fears that you spoke to, right? Of like, is this tool going to take my job? But also, I think with curiosity, we can find ways to integrate these tools into our practice and potentially enhance the care that we're able to deliver. Whether that's doable right now, I think is questionable because these tools are like still very early on in their development. But I'm talking about in the near future when these tools become more popular. And I think, without that curiosity, there's a chance of falling behind, but also the curiosity allows you to explore tools that work with you and work with your clients, or work for you and for your clients, as well as also identify ones where you say like, oh no, this style doesn't at all work with what I normally do. And so I think in that regard, curiosity is probably the most important aspect here because it's an exciting future. We see these models improve so rapidly. And I think, yeah, only time will tell what we'll be able to do with these because we know as humans, we're terrible at predicting the future.
That's a good prediction.
Yes.
Philip, I want to thank you very much for being with us and for your time and ideas and creativity that you bring to research and therapy. It was a pleasure. And also to say, I think of connecting it with the personal story that you have. It's really amazing that you are doing this work and making a world with better treatment and better options for clients with PTSD and maybe clients in general. So thank you very much.
Yeah. Thanks for having me.